All right. So, step one, USMLE Neurology, first video today. Continuing on with providing you high yield questions and teaching value to each and every student out there. So, as always, I will be expecting you guys to pause the video and read the question yourself, and then we will discuss it. All right. So, basically, this is an easy question to start of this series. This is a very easy question. So, a man with autosomal dominant polycystic kidney disease presents to the emergency department with sudden severe headache and confusion. And there are no meningeal signs and no focal deficits. And there is a head CT that is given that you might have already seen in the next slide as I was going through the slides. So, to make it easier for you, we have broken down the findings in separate sentences, which is given in the question. It's already given in the question that he has subarachnoid hemorrhage and he also has delayed right-sided weakness, which means that this is not the initial presentation, but the weakness did occur after some time, not on the first day, but on the fifth day. So simply asking which medication would have prevented the in-hospital neurological complication, which is basically pointing towards this complication, the delayed complication. So they've already given you subarachnoid hemorrhage, but you have to know it's very high yield for the exam that what is the presentation of subarachnoid hemorrhage. So I think we're going to start off by discussing that. Subarachnoid hemorrhage presents as a severe headache and confusion. Likewise, in this patient, it may be described as thunderclap headache in most resources. It may be described as worst headache of my life. Now, that sentence will not present in the question stem, but it does present in many other ways, such as the patient might say that I have never encountered this kind of headache. Uh, the patient may say that this is like this pain corresponds to being hit with a bat. Like it would feel like that I was hit with a bat. They could also say that the headache is acute. Now, this headache is not slowly progressive. It's not. It is an acute presentation. And unlike migraines and tension headaches, this does not increase over time. Subarachnoid hemorrhage also presents with associated symptoms such as neck stiffness, which is also known as meningismus. It also presents as nausea, vomiting, photophobia. It can also present as loss of consciousness. So don't rely on whether that loss of consciousness is present or not. Don't rely on that. I've seen it present both ways. So meningismus basically comprises of symptoms that you might see in meningitis, such as stiff neck, headache, stiff neck mainly. So those symptoms can also occur in subarachnoid hemorrhage. And I've seen students slip on that because they are expecting those symptoms only for meningitis cases. And that's not how they always present. They can present in intracerebral hemorrhage. Mostly they would present in subarachnoid hemorrhage. Now that is the initial presentation. And since they've already given you the diagnosis in the question, they don't expect you to diagnose it. But you should know that the initial presentation is more important because that's how initially the patients present. What they're asking for in this question, which makes it slightly difficult, is pharmacological uh, question regarding what is needed to treat the delayed complication. Subarachnoid hemorrhage has many acute complications, but one of its delayed complications is that after some days, for some reason, the cerebral arteries can undergo vasospasm. And when they undergo vasospasm, what happens is that focal neurological deficits arise. Now, focal neurological deficits will not be present in the initial presentation, but they will be present. They will be present when the cerebral vessels undergoes vasospasm. Now, why does the vessel undergo vasospasm? It's a different story. Basically, what happens is that the vessel has hemorrhage that is concentrated at any site. What the hemorrhage does is that it starts to attract inflammatory cells, and they start to release cytokines. So what the cytokines do is that they start to contract the vessel. So a vessel that is already occluded starts to contract after some time. And what it does is that the area that the vessel is applying at becomes ischemic, and then focal neurological deficits. Yes. One high yield detail is that the head city. You have to know how the head city presents. This is a high yield picture. So this is a slightly difficult picture. The exam usually gives you an easier picture, but this is slightly difficult. But I'm going to tell you this one trick in which you can easily identify that it is a subarachnoid hemorrhage. For one, you have to know the pictures of epidural and subdural hematomas. Those are very high yield. But to identify a subarachnoid hemorrhage, what is important is that they would mostly also describe in the question, if they're describing a CT, if they're describing an image, they've not given you an image, but they're describing the findings. What they would say is that there is hyper intensity in the basal cistern, hyper intensity in the basal cistern. And this is the basal cistern, this starfish like shape that you are seeing. You know, the starfish like shape. This is the basal cistern. And you know that the blood appears as hyper intense on non contrast CT. So, what they would show you, what they would tell you is that there is hyper intensity in the basal cistern, and that is how you would identify that it is a subarachnoid hemorrhage. The other way it can present is they could give you the same image, an image like this, a CT image, and the best way to identify is that you have to identify the starfish like picture. You have to identify this, and then if this is white, you know that this is subarachnoid hemorrhage. That's it. You will not get this kind of a CT image in any other pathology. This is how subarachnoid hemorrhage is visualized, is that a starfish-like pattern is appears white, appears hyperintense. So you have to remember this image. Moving on, these options are also high yield. All of these are important. So basically, what is a pharmacological agent that might prevent vasospasm, right? That might prevent vasospasm. That's what they're asking, vasospasm. So the correct answer is calcium channel blocker. And the reason is that calcium channel blockers, they block endothelial cell calcium channels, which in turn lead to relaxation of the endothelial muscles, smooth muscle cells of the vessels, and the vessel expands. The vessel will not constrict or contract. The endothelial muscle will not contract, and the vessel will not constrict. What happens is that the vessel stays dilated and there is no ischemic damage to any focal tissue. So this prevents vasospasm. You should know this is high yield. Discussing other options for ACE inhibitors, you must know that this is an antihypertensive agent. This is used for proteinuria, and it can be used in autosomal dominant polycystic kidney disease, but for preventing proteinuria or hypertension, for treating hypertension. Beta adrenergic blockers is the wrong answer because it may also control hypertension. It has nothing to do with vasospasm, preventing vasospasm. It's not a CNS acting drug. Central sympathogenic, basically, it can refer to clonidine, which means that it reduces the blood pressure, but it has no role in subarachnoid hemorrhage. It has no role in that. And it also does not prevent vasospasm. Nitrates, such as nitroglycerin, can be used in angina or heart failure, and it's not indicated in subarachnoid hemorrhage. Osmotic diuretic such as mannitol may be used in intracranial hypertension. It is used acutely to reduce the hypertension and to reduce the ICP, the intracranial hypertension. So it has no role here. And diuretics are used for hypertension, but it does not prevent vasospasm. So you have to know that calcium channel blockers, such as nimodipine, can be used to prevent, they are used to prevent vasospasm and any delayed focal neurological deficits. And these can occur between 4 to 14 days of initial bleeding. So you have to remember that. Not necessarily the time, but the fact that it is a delayed presentation. Also, one high yield thing that I almost forgot to discuss is that AD, autosomal dominant polycystic kidney disease, has a strong association with aneurysms, cerebral aneurysms, berry aneurysms, and liver cysts. So liver cysts and aneurysms in the head, and the aneurysm ruptures, and that is the most common reason of subarachnoid hemorrhage. So that is how you know that both are associated. Autosomal dominant kidney polycystic kidney disease is associated with brain aneurysms, and in turn, these aneurysms are associated with intracerebral hemorrhage or subarachnoid hemorrhage. That is what you have to keep in mind. There is an association there. Autosomal dominant, of course, in adults. Autosomal recessive, of course, in kids. Autosomal recessive is in kids. So that's easy to remember. Again, remember the association that autosomal dominant is associated with the brain aneurysms and liver. And I think that's it for this question. So easy question to start off with.